So we just thought it would be interesting because it's always nice to know what each other are doing and what we're working on, etc. So I've just got three initiatives just to share with you guys so that you know what goals working on, what we've got planned, and what's underway at the moment. So if you go to the next slide, please. So this is the first initiative. You go to the next slide, is I'm going to talk about is the Multi-MUAC tape. So just to give a little bit of history, in 2022, the MAMI Global Network convened. There was a working group to tackle challenges in accessing or producing quality MUAC tapes for infants that also took into consideration the material thickness to provide accurate measurements. So although, I mean, GOAL have been using sort of we've been working on various iterations of an infant tape since 2019 in Ethiopia, the template, the print spec, and the manufacturer, all of that information has been available on the ENN MAMI website for a number of years. But what a lot of partners were saying is that replication at scale was very difficult. What the MAMI network did is convene this working group to try and look at designing something uniform that all of us could potentially use. So if anyone wants to read a short piece around the systematic bias of tapes that aren't corrected for material thickness, there's a link I've put at the top of the screen. And it's a technical note that was published in 2021. And it explains why there's a constant error of it's to the human eye, it looks like it's around 2 millimeters for tapes with a material thickness of 30 microns, 0.3 millimeters, which is the UNICEF technical specification for the minimum thickness required for MUAC tapes. And just a sort of interesting side, the error for any specific thickness remains constant despite the different circumference. It doesn't matter how tight you pull the tape on the child, you know, whether it's a teeny weeny child or anyone slightly larger, the error remains the same, and that's due to an effect called the string girdling earth mathematical puzzle. So you can read about that if you want to. It's in the link in the technical note. But it's just to say that unless tapes, the artwork on the tape does take into consideration the material thickness, there is a systematic bias. So what it means is when we're looking at the reading on the tape, we're actually reading the measurement of the child's mid-upper arm circumference and also the thickness of the tape. So we get about a 2 millimeter bias or 2 millimeter error. So back to the problem of working on new tapes at scale, the working group oversaw the design of a pilot, what we called the Multi-MUAC tape. And it was produced by UNICEF Supply Division in collaboration with WHO. And the tape was designed to be one, high spec, and practical, two, to support the assessment of mothers and infants together, and three, it was to also include the older children 6 standard MUAC cutoffs for older children 6 to 59 months. So the idea was that it reduces the need to have multiple MUAC tapes, and it was to support the use of MUAC identification in community settings as well as by health workers. So operational pilots were conducted by GOAL in Ethiopia, Save the Children in Kenya and Somalia, and Momentum, part of the USAID MIHR project in South Sudan. And in summary, it's all been printed up in Field Exchange, but in summary, what we found is that both health workers and caregivers were able to use the tape to screen infants under 6 months, as well as the other demographic groups. But there were several learnings that emerged. And based on the learnings and aligned with the 2023 WHO guidance that recommends a single cutoff of less than 110 millimeters, we've revised the design again and developed a newer version called the Multi-MUAC version 2, which is what you can see on the screen at the moment. So in terms of the details, so there's two sides to the tape. There's the standard MUAC tape for children 6 to 59 months with the standard red, yellow, green cutoffs for severe and moderate wasting at 115 mils, 125 mils. And then the second side of the tape includes infants 0 to 6 months and pregnant and breastfeeding women. So in this particular design, what we had decided was to go with the WHO guidelines with a cutoff of 110 mils for children under 6 months requiring referrals. But instead of applying it, the only difference is instead of applying it from 6 weeks to 6 months, because we have the capacity to support a higher caseload, what we have done is just applied that setting to all children from birth. So, so we've got a blanket approach for all children under 6 months. Previously, in the first iteration of the tape, we were using 2 cutoffs. So we used 110 just for the teeny weenies, birth to 6 weeks, and then we were using 115 from 6 weeks, so after that point of first vaccination up until 6 months. And then we're using a 230 mil cutoff for pregnant and breastfeeding women, because this is what aligns with the South Sudan national guidelines. Another key feature is that the tape is laced through 3 windows, 3 quite narrow windows. And the point of that is it reduces the lateral movement of the tape up and sort of wriggling it up and down. So it improves the movement accuracy. Okay, Ray, can you pop to the next slide, please? So how does the version 2 MUAC tape compare to the previous version? So the first version of the tape, the prototype that was produced by very kindly by UNICEF. So I've just got up on the screen just a quick table that shows the differences. So what we've got is the original. Actually, was it UNICEF or was it? No, I'm sorry. I think this is meant to have read the WHO mother can correct me. WHO mother UNICEF tape. So the newer tape has a color coding scheme of blue, green, and violet. Whereas the version 1 and the version 2 tape, what we've done is just stick to the standard colors of green, red, and yellow, just because that was the feedback we got from community as they understood that. Health workers understand the traffic light system. The target groups for the WHO tape are pregnant breastfeeding women and infants 6 weeks to 6 months, as per the 2023 guidelines. Whereas the Multi-MUAC does PLWs, infants from birth to 6 weeks, and then the older standard cohort, 6 to 59 months. The cutoffs being used in the WHO tape will depend on context, so either 23 centimeters or 21 centimeters, and then the new 110 millimeter for children, for infants 6 weeks to 6 months, for the UN tape, and then for the Multi-MUAC. The previous version, as I said, we were using 2 cutoffs, so less than 100 and then 110 mils for the little babies, and then less than 115 for those from above 6 weeks up to 6 months, whereas now we've just got the standard single cutoff of less than 110 mils for all infants under 6 months in this new design tape. So, but it is important to flag, and this is something that Marco's very good at reminding us, is we need more information on the cutoffs, the MUAC cutoffs of infants under 6 months. So the WHO recommendations that are in place, they were based on an evidence base that were described as limited. So we do need to collect more information, and it's important that, where possible, we look at trying to include probably a larger demographic group, so we're able to collect that information and see what the outcomes are for those infants, so that we can start contributing to a more significant, a more substantial evidence base, because we don't want to get stuck with a cutoff that potentially isn't the right cutoff, but at the moment it's based on the evidence that was available. Next slide, please. Okie doke. This is just to run you through. So we're going to be piloting this version 2 of the Multi-MUAC tape in 3 locations in South Sudan this year. Between September and December, it's going to be rolled out in 3 locations: Twitch, Renk, and Mango. And they're all ECHO-funded programs. And the pilot's going to be funded through a private donor, and we're going to roll the family MUAC approach using this Multi-MUAC version 2 design across about 52,000 households. But what we're going to do is focus on a much smaller sample going to be selected for testing. So in each of those 3 locations, we're going to be taking around 500 households. And there'll be 2 phases. So first phase is the health worker training and testing. So in each location, a health and nutrition officer, a more senior individual, is going to train about 10 health workers on how to use the tape, and also how to identify edematous malnutrition. And then each health worker is going to measure the MUAC of 5 different infants. That's going to be recorded. They're going to record the MUAC color classification and also the numerical measurement. And then the officer who's training these health workers is going to take the same measurement on the same infants for comparison, and the health workers will be asked to correctly identify cutoffs for at-risk classifications and what the corresponding actions would be. So to test their understanding of what does it mean if you classify as the different color categorizations. That will be applied to infants under 6 months, children 6 to 59 months, and also pregnant and breastfeeding women. The data is going to be collected on, 1, the accuracy of health worker measurements, so sensitivity, specificity. 2, the comprehension of risk markers shown on the tape. So what does it mean in terms of where are they referred? Do they need to be referred, and what information is given to them? And 3 are the challenges faced. So any challenges they encounter whilst trying to use the tapes, and any suggestions for improvement. So for example, it might be, ease of use of the reversible tapes or something. So it's very similar to the pilot that we did originally. It's just a slightly different design now. So we're just retesting it. The phase 2 is the cascade training down to the families. So what's going to happen is those health workers who demonstrated a proficiency to use the tape accurately, they will conduct the cascade training to about 50 families per location. So they obviously have to have infants under 6 months. And they will also be trained on how to use the tape and how to identify edematous malnutrition. So trained family members are going to be asked to measure their infant's MUAC with the health worker recording just the color. We're not going to ask them to look at any of the enumeration. It's just the color for families to use. The results are going to be compared against a verification measurement taken by the health worker on the same infant. And again, data for this cohort is going to be on two elements. So comprehension of risk markers by asking which colours indicate the need for referral of the demographic group, if it's infants, older children, or PLWs, and the challenges faced using the tape again. So any sort of issues with regards to lacing it together, or reading the colours, or interpreting the results. So this is going to happen later this year. Well, September we're starting it until December. So we will look forward to sharing the results with you early next year. And we also hope to roll out the tape in Ethiopia next year, either the same version or a slight modification. Next slide, please. So the next thing I just wanted to flag with you is the MAMI MOYO charts. So I don't know whether people have come across MOYO charts already. They were first designed in collaboration with LSHTM in Malawi many years ago. They're fantastic tools, and they're to help the early identification for anyone with acute malnutrition. So they are basically a growth monitoring a tool where you can help to identify weight for age Z scores. We're going to be using them to identify weight for age Z scores as a key marker for identifying infants requiring support. So just to what Ray's got up on the screen now is just an example of the current lookup tables, the WHO growth charts or lookup tables that health workers have to consult. It's a sea of numbers, and the risk of misidentification of the correct score is very high. And there are lots of errors in interpretation and misreading and misdiagnosis, and therefore obviously delayed support to correct children. So next slide. We have the Moyo charts as a much simpler alternative. So I've tried to put the picture in the left-hand side. I've actually got an example. Eilish had one with her, and I just pinched it off her, but I don't think you can. I don't think I'm up on the screen. But they provide a much more intuitive way to support health workers so that they can rapidly and accurately classify Z scores, even in sort of challenging settings. So they were developed by LSHTM for 6 to 59 months, and they've been extrapolated to include infants under 6 months in the last few years. They effectively, all they do is they repackage the WHO tables into a very easy to use slide chart, and there's a window through which the health worker reads the results. So I've tried to, you can see at the top, there's you pull the page up and down, and where I've got the little blue marks, that's where the age, you read the age of the child. So health workers can only see the relevant data for that infant through a cutout window, and it hides all the other confusing data, and it helps just to avoid those lookup errors and reduce confusion. So in terms of, for those of you who aren't familiar, I'm sure many of you will be, but for anybody who isn't, basically you select the correct side of the chart. So there's a front side and a back side, a male side on one side and a female side on the other. And then you locate the child's age. So Ray, if you click, there should be some little blue circles. So there's 2 circles because there's younger children on one side and there's older children on the other. So you just slide it up and down depending on whether you're looking at the younger children on the left-hand side or the slightly older children on the right-hand side, until you slide it upwards until the infant age appears in one of those little circles. So the weeks are displayed until 13 weeks. And then from 3 months, which is the equivalent of 14 weeks onwards, it's shown as months as per the WHO growth tables and the WHO centile curves on the charts. So the rationale is based on the reason why we've got weeks to start with and then we move to months is that there's obviously rapid growth and developmental changes in the first few weeks and months of life, which require more granular tracking. So that's the reason why we've got weeks and months. And then what you do is you literally just read across. It's a little bit difficult to see, but Ray, if you click again, if you read across, there we go, just read across, if you happen to be on the left-hand side, where the child falls. Do they fall into, are they less than the red category, the yellow category, or the green category? And then the diagnosis is then to look down at the next stage. So I think I've got, yeah, if you click again, the diagnosis is underneath. There's that little box. So if it's red, it then tells you the child, has a risk of severe acute malnutrition, and this is what you have to do. So you just look, it then tells you the color coding, and you just determine the infant's risk. So those are the that's the what it looks like. Can you go to the next slide, please? So after the MAMI MOYO was developed, I'm just going to tell you about the study, the original because it was originally developed for older children, and then the MAMI MOYO was developed to include babies from birth. And a study was conducted in the UK, and it was piloted with health and public health professionals. So not in a low resource setting, we're in a high resource setting at the moment. And professionals, what happened is they were provided with hypothetical scenarios, and then under timed conditions, but in random order, they either used the MOYO chart, the WHO lookup tables, or the WHO growth charts to determine what the infant's status was. And then the diagnostic accuracy and the response rates were compared between those three different options. And the evidence from the UK study, if you click again, I've got a little box showing the results. So what it showed is that health workers in the UK who used the MOYO charts, they achieved about 79% accuracy, with each assessment taking around 42 seconds. So what that equates to, it's around 85 correct assessments every hour. When it was compared to the same individuals using the WHO lookup tables, there was about a 70% accuracy, taking about 48 seconds per correct assessment. So that's around 75 correct assessments per hour. And the growth charts reduced to, there was only a 61% correct assessment. It took quite a lot longer, about 1 minute, 9 seconds per correct assessment. And that would have resulted in around 53 correct assessments each hour. So those findings are quite useful to demonstrate, especially in low resource contexts, the different timings that they take, but also where the errors are more common. So we can see which one, has achieved best in terms of accuracy in a high resource setting. So using the goal, we are very lucky. We've got an internal innovation fund for small amounts of money. So we're going to be piloting the MAMI MOYO in Ethiopia, in Benishangul Gumuz region, again between September this year through to February next year, 2026. And it's in our MAMI programs where we're providing MAMI support as part of the care package, supporting South Sudanese refugees. So this is in refugee context. It's not through the Ministry of Health. So we're going to be using the same chart design that was used in the UK assessment with some minor adaptations. So there's a bit of change in imagery on the chart, and we're removing, previously there were half months included, and we're just presenting the information from 3 to 6 months as full months, which aligns with the WHO lookup tables, because that's what people are familiar with. And they're also obviously comparing the other nodes. So just as a side note, as part of this pilot, we're also going to be piloting for older children the use of the weight for height MOYO charts that's already readily available. We're going to be doing that in Tigray and Amhara. So the weight for height MOYO tool was tested originally back in Ethiopia in 2009. But it was only tested with medical students. So this pilot is going to be, will provide critical evidence to drive the acceptance and wider adoption of the tool more generally in low resource settings. Okie doke. Third and final, just very quickly, if you go to the next slide. So alongside the MOYO charts, what we're going to do is we plan to pilot something that GOAL have dubbed the ZCALC app. It's still under design. The picture on the right hand side is just a sort of holding picture. But what it is a free and very simple, very basic app for health workers with smartphones or computers to be able to, it's an alternative to the MAMI MOYO chart. So for those people who do have smartphones, they can download the ZCALC app. It replaces paper-based solutions or more complicated digital solutions. There are already other solutions out there. But it's because it's, once you've downloaded it, you can then use it completely offline, and it's basically a calculator. And then other solutions that are already out there, we looked at, but they only identify weight for age or weight for height, but not both of them together. So workers will simply input, all they will have to do is put in the child's or the infant's sex, their age, their weight, or their height if they want to look at weight for height, and then the app instantly calculates the correct Z score. So it eliminates any of those calculation errors that we were seeing using the lookup tables. So it will calculate the weight for height or the weight for age, and it provides immediate feedback on the child or the infant's risk classification. So it enables timely referrals and better care outcomes. So yes, just to stress, it works offline, so it overcomes a lot of the barriers where there's limited access. So this is going to be piloted in Ethiopia between September and February. We're going to be piloting the ZCALC app and the MOYO charts. They're going to be tested together. The MOYO charts will be done in areas with poor smartphone access, so health workers who don't have smartphones. The ZCALC apps will be in clinical environments or health facility environments where there are smartphones available. And they're going to be, the ZCALC app is going to be piloted in Benishangul, Gomez, alongside the MAMI MOYO charts, and also in Tigray and Amhara alongside the weight for height MOYO charts for older children. The control group's going to be using the WHO lookup tables, and the pilots group will be using the charts, the MOYO charts and the ZCALC app. And the evaluation is going to happen immediately after training and then follow up at 2 months and 4 months to assess retention and performance. Just in terms of their potential, the MOYO charts, the only cost is printing. The ZCALC app is free. It's going to be open access. So, anyone who wants to use it, it will be free to download and available to all. There's low or no cost, the low or no cost of these initiatives makes their inclusions in national budgets feasible, we hope. I mean, the ZCALC app will be free, but the MOYO charts is just printing costs. And they're very simple, they're user-friendly, they require minimal training, and there's also strong potential for wide-scale adoption and rapid scale-up in Ethiopia and/or beyond. So again, we will come back and we'll share the results from this pilot early next year when we've got results. All righty, thank you.